Good afternoon, everyone, and dear committee and dear colleagues. Let me present my PhD topic, Advanced Strategies in Improving Outcomes During Mechanical Ventilation. My name is Csenge Szigetváry. I'm currently working at the Department of Anesthesiology and Intensive Therapy in the Semmelweis University. And I would like to say a special gratitude to my two supervisors, Zsolt Molnár and Zoltán Ruszkai, for this whole 2 years behind us. Our vision was to implement more personalized strategies in intensive care medicine, and by that to help disseminating a scientific-based medicine which is beneficial for the patients in intensive therapy and in anesthesiology as well. Over the past 2 years, I've been working on 3 projects. And I would like to start with the first one. Individualized positive and expiratory pressure settings may reduce the incidence of postoperative pulmonary complications. This is a systematic review and meta-analysis. Well, during general anesthesia, various factors occurs in the loss of muscle tones, especially the loss of respiratory muscles as well. And this will lead to an altered and non-physiological respiratory mechanics, leading to atelectasis, progressive atelectasis, even in otherwise healthy patients and in healthy lungs. And in order to prevent that, we use positive and expiratory pressure, PEEP for short, as a part of the lung protective ventilation to keep these closed alveoli open and improve oxygenation. But a high PEEP may also cause harm by overstretching the lung tissue. And here comes the individualization by titrating the PEEP and by tailoring the PEEP to the person, to the patient, in order to both reduce the incidence of postoperative pulmonary complications and to both maintain a good oxygenation throughout the surgery. So for this review, our question was whether the personalized PEEP titration methods results in better perioperative outcomes as compared to conventional settings, which are usually fixed PEEP settings. And we investigated patients undergoing abdominal surgery, and we were mainly interested in the incidence of postoperative pulmonary complications and also in perioperative oxygenation and respiratory mechanics as well. Throughout our systematic research, we identified 17 eligible randomized controlled trials to be analyzed, and now I would like to show the results. First of all, what was the value found to be optimal through the PEEP titration methods? We detected an averagely almost 6 centimeters of water higher PEEP pressure required when the patients were when the patients used individualized PEEP compared to the conventional setting, which is most of the cases were around 6 or 5 centimeters of water in the first place. So this is a highly relevant number. As our primary outcome, the postoperative pulmonary complications, we detected a reduction of possible postoperative pulmonary complication incidence. However, this result was not significant, but it showed a high tendency. To assess oxygenation, we used the PF ratio, which is the arterial oxygen pressure over the fraction of inspired oxygen. And the higher this ratio is, the better the oxygenation status the patient has. And we investigated the end of surgery PF ratio of the patients, which was on average about 50 millimeters of mercury higher in the group where the patients were ventilated with an individualized PEEP setting. This wasn't only statistically significant, but this is a clinically significant improvement in oxygenation as well. As a conclusion, we can say that based on our findings, the individual PEEP settings were nearly 6 centimeters of water higher on average. It may reduce the incidence of postoperative pulmonary complications, and it resulted in better postoperative oxygenation. Due to the lack of time, I could not really show other forest plots, but we detected a better lung mechanics indicated by compliances. And we also detected a higher chance of hemodynamic instability in the intervention group when individualized PEEP was used. As a summary, the strength of our study was that it only included randomized control trials, but the big limitation is due to the heterogeneity both of the population we investigated or that were included, also the intervention, because these titration methods may differ, and also the comparator PEEP values differed throughout studies. Outcomes were measured at different time points, and therefore in the future the implication for further research would be to conduct RCTs in a more homogeneous population, surgery, and to have a consensus on how to titrate PEEP, which is the best titration method and how to titrate with that method, and to define appropriate time points to measure. And the implication for practice is to improve the oxygenation and reduce the postoperative pulmonary complications by personalizing the ventilation settings throughout the surgery. Currently, we are just before the fourth submission. Our target journal will be Acta Scandinavica Anesthesiologica. The second project I worked on was hemoadsorption as adjuvant therapy in acute respiratory distress syndrome. This is usually a secondary result of a dysregulated inflammatory host response, and immunomodulation by removing the cytokines extracorporally may be beneficial for the recovery of the lung in the early course of this disease. So our question was whether this therapy in refractory hypoxaemic respiratory failure can hasten improvement lung recovery. The patient population would be patients with ARDS, and we investigate those who underwent hemoadsorption therapy as an adjuvant therapy, and if we had the chance, we compared them to patients only undergoing standard medical treatment. We were mainly interested in before and after oxygenation parameters. Also, due to the lack of time, just a few forest plots. It's the same PF ratio I've mentioned before, so the higher, the better the oxygenation is. And on this plot, we could see that on average, the patient who received the hemoadsorption therapy had a nearly 70 millimeter of mercury higher PF ratio at the end of the hemoadsorption session compared to the before value. We also detected a reducement in the inflammatory markers in the CRP, just reaching significancy. This was further supported by individual data as well, because we mostly worked from case reports and case series in this topic, since the field is really under-investigated at this current time. So these are data from case series and some retrospective studies. The strength is that this is so far the first systematic review that examines this topic, hemoadsorption in ARDS. And the second line is already a limitation, because we only have a small number of studies available with small number of patients. Sometimes they were pulled inadequately, and also the level of evidence when it could have been measured, it was low. The implication is to conduct further RCTs on this topic and draw a much firmer conclusion on how to use this therapy, when should it be applied. As a conclusion, our findings showed some positive results regarding the oxygenation and some positive results on reducing the inflammatory mediators. The third project I have very shortly, it's going to be an initiation of a registry on acute hypoxaemic respiratory failure. We would like to collect high-quality data on standards of care and procedures, as there are currently neither registries in critical care in general, nor in this topic in Eastern Europe. We have already defined our eligibility criteria for this registry, and we hope we can move on with this project as soon as possible. This belongs to the previous topic, the hemoadsorption therapy. It's currently under review at critical care. So as a summary, these were the 3 projects I've been working on, and I would like to thank your attention and help in these 2 years.
Congratulations for your nice presentation. I would like to ask you more, please explain me why on the second topic CRP is important as a measurement, and why do you choose that outcome?
We chose this outcome because, as I mentioned, this disease, ARDS, is it's usually a host response to some initial damage, and it has a strong connection with the inflammatory status of the host. And although it can be misleading, maybe this parameter, but so far this is the only parameter we have, a very few parameter we have, and we just try to collect as many data as possible regarding the inflammatory status of the patient. Maybe not the most specific, but that's what we have and that's what we could analyze.
Did this RCT is reporting procalcitonin level, maybe? But it's going to be interesting to compare that to...
Sometimes, and I would like to highlight again that these are not RCTs. So most of the time, they are just case reports, they are case series, and probably tests weren't ordered as precisely in order to have data later and draw more conclusion about them. So this is what we can work from at the moment.
Okay. Thank you so much.
Thank you. It was an amazing presentation. I have a question regarding your first topic. You said that one of the limitations was that you had a heterogeneous population, but as I've seen in your primary outcome, every type of population shows some decrease in post-operative pulmonary complications, so it can actually be a strength that, and it can support the generalizability of your results. What do you think about that, or how can you handle this statistical heterogeneity?
We try to handle it by subgrouping these patients. We subgroup them either by, so not just either, I will show you, because there were both laparoscopic and laparotomy surgeries involved, which highly affects the number of the required level of PEEP, for example, which may lead to heterogeneity if we don't separate these patients. And also, we try to do subgroup analysis on obesity as well, because these are very important confounding factors when it comes to find the optimal PEEP for a patient. So this way.
Okay, thank you.
Thank you.
If I may start, For the first one, your primary endpoint was PEEP in centimeters of water. But what were the absolute numbers? So the difference of 6 centimeters is a huge from my perspective. But what were the absolute numbers?
The absolute?
Yeah. So was it 7 and 13, or was it 1 and 7?
Well, on average, it was less than, definitely less than around 8 in the fixed setting.
8 in fixed and 2 in individualized?
No. I think around 10 in the, or maybe I don't understand the question.
Okay, so you are demonstrating that people in fixed PEEP group had 6 centimeters of water higher PEEP.
No, in the individualized group, not in...
Individualized, they had lower or higher?
No, in the individualized, they had higher, 6 centimeters of water higher when the PEEP was individually titrated.
So they had higher PEEP?
Yes.
And what were the absolute numbers?
I don't know.
Okay, because that would be relevant for me.
I can only say what the forest plot is telling us about the average, the means of each study in the intervention and in the study group, in the control group. Throughout the control groups, you can see that it was 4 to 10, in the range of 4 to 10 centimeters of water. Most of them were 5, 6 centimeters of water. And in the individualized group, it wasn't rare that the PEEP was the mean PEEP in the control group were over 15 centimeters of water as well.
So high?
Yes.
Okay.
Especially if we watch in the subgroup on the top. It doesn't work. The obese laparoscopy, they required the biggest difference as the initial as an initial fixed PEEP. Sometimes they use 10, and on the other side, as you can see at Eichler, 2080, it was reaching 20.
Now, do you agree that individualized PEEP patients had higher PEEP? Does this make sense?
Yes, I think it makes sense.
Makes sense. Okay.
Yes.
Now the second one, you mentioned something about obesity, but did you also investigate whether there was an effect of sedation duration, so ventilation duration, sedation duration, obesity, you mentioned this a bit, and pre-existing disease, like somebody with heart failure or somebody with something? Did that play a role? In particular, with regards, and here is the main question, you are telling that this may affect incidence of pulmonary complications, but you didn't state the definition. So what is that?
Okay, so the first thing is that luckily, in this way, the studies were homogeneous, that most of them only included patients without any previous cardiac or pulmonary disease. So it was a criteria for them. And the second question, which was
definition of postoperative pulmonary complication.
That's a very heterogeneous thing. What is the definition of postoperative pulmonary complications? There was a consensus on it in 2018, suggesting to what is to be considered as a postoperative pulmonary complication. But as you can see, some studies are published before that, and those who were published after this consensus didn't always use that. So,
like usually in clinical practice.
So.
Yeah. Okay. Then my suggestion to you: you are now with the 4th journal, aren't you?
Yes, we are.
Did you receive any good comments by the reviewers?
Yes, just recently.
Just recently, okay. Because the fourth submission tells you that either you are unattractive or there is something wrong. So maybe rewrite some sections, or I don't know. And then the second one, because of the problems you have described, would it make sense to do the national randomized controlled trial in that? Because in Hungary, how many surgeries per month would be eligible for the study?
I don't know whether another randomized control trial would be needed on the field. Yes.
I would say yes, but okay. Then now the second one, you have a meta-analysis of about 100 patients, and the primary endpoint was PF ratio and secondary was CRP. I share the comment that there should be some other markers as well, but the largest study I think had 50 patients or something like that. And my question again, wouldn't it make sense to do the proper prospective observational study first? Like within Hungary or within, and I'm looking at Zsolt, who is the father of many things, including sepsis, sorry. So just to see what is the clinical practice, when do we use it, and what are the effects?
Yeah, definitely. It would definitely make sense.
Okay, I'll stop here.
Can I ask what the comments were for your paper?
One of the comments, which I agree with, was that it's not on this slide specifically, but we also included, for example, 2 studies that as a fixed PEEP strategy, they used the ZEEP strategy, which is not applying PEEP, which it really makes no sense if we want to compare the pressure results. It probably would only make sense if we want to compare approaches or methods, but wouldn't help us draw firmer conclusion on PEEP itself. That was one of the comments.
For your valuable comments. Concerning the first meta-analysis of yours, do you have any data on what was the postoperative pulmonary complication that they have described in the randomized trials, like PTX or barotrauma?
Atelectasis measured by a lung ultrasound.
In which group? In which group?
Both groups.
Both groups.
Yes, yes. And hypoxaemia, usually defined as lower saturation than 90. Pulmonary infusion and pneumothorax.
Do you know the percentage of the complication rate of these trials?
Not exactly, but the most common that the trials defined, they used either hypoxemia or atelectasis.
And are you aware of the duration of the operation that were defined in the randomized trials? Was there any difference between the 2 groups of the individualized PEEP and the fixed PEEP groups? Was there any difference between the duration of the operations? Because there are some patients without any defined surgical approach.
As far as I remember right, there were no difference between the durations. And this was one of our conclusions, that it doesn't lengthen the surgery itself, the preparation and the start of the surgery to do this PEEP titration at the beginning. So it wouldn't cause a longer ventilation to perform this and longer surgery.
Yes.
Yeah.
Okay, and last question, what was the cutoff rate in average between the obese and non-obese patients?
The cutoff range wasn't defined by us,
Of course
but
not.
but the,
And the RCTs?
35 BMI of 35 or over.
35? It's
Or
rather
40.
high.
Yeah, because these were obese patients that underwent gastric bypass surgery, so they were really extremely obese. That must be the reason for the high value.
Was it an American RCT or?
Most of them, and German.
Thank you. And the last question from me. Based on your knowledge and covering all the RCTs that use the individualized PEEP, what kind of strategy would you like to suggest us anesthesiologists to use for laparoscopic and obese patients?
For example, to do recruitment maneuvers before the surgery, after induction, and to try to reach a good pulmonary compliance, the lowest driving pressure as possible by adjusting PEEP to the needs of the patient, and to keep our eyes on the monitor.
Of course, we do it in the real life, yes, thank you. But how long would you like to titrate it before starting the operation?
How long?
Yeah. How long does the surgeon has to wait for you? Because they are always impatient.
Yes, yes.
They are not patient, but impatient.
But I think, although I'm really not an expert, but I think that after a pneumoperitoneum is applied, and if the patient is stable, we don't see anything not to do a recruitment maneuver, then we can do it parallelly, I think.
Leave them go. Okay, thank you so much.